All right. Thank you very much once again. You're welcome. And I'm sure that it's going to be a very rewarding period for us. Um, we're going to be looking at hypertension part two. So let's talk about hypertension. I'm Akinsanya Olusegun Joseph. I'm a cardiologist and I have other doctors. We have other doctors in the house. And I just want to say shout out to everyone who is here today, despite a very, very short notice. All our friends and all, you know, people that have made that time to come around. And I want to also say shout out to all the doctors that are in this meeting. I want to believe that it's going to be very, very engaging. Thanks to everyone, Dr. Obieli, Dr. Donye, my good old friend, Dr. Onyocha, Kenneth, and everyone that is here. It's going to be very brief, and then we will go into Dr. Taiwo, you'll recognize, and everyone that is here, and all our very wonderful people that are here. Thank you very much for making our time to come. So let's talk about hypertension part two. We looked at part one 2 weeks ago, and we defined hypertension. We looked at the risk factors. For those who are not around 2 weeks ago, we said hypertension is chronic, sustained elevated blood pressure, and with going by the WHO classification, it's blood pressure of 140 over 90 and above. And if you're living in the US, hypertension is defined as blood pressure of 130 over 80 and above. So if you live in the US, for you over there, hypertension is defined as a blood pressure of 130 over 80 and above. I mean, if it's sustained. Of course, we looked at the risk factors of hypertension, the essential hypertension. We talked about the types of hypertension, primary, secondary, and then we looked at some other classifications, max hypertension, white coat hypertension. If you want to catch up on that, the recording is available. We can send it to you. So we're not going to really waste time on that one today. We've covered the risk factors. We've looked at the fact that hypertension is a global, issue, a global, challenge, and we need to deal with it. Today we stopped, and then we'll look at clinical features and then complications. And after that, we will give time for um, for interaction as usual. All right. So this was, if you remember very well, we said that the impact of hypertension is global. The impact of hypertension is very, very significant. We look at the fact that hypertension accounts for the highest, death globally. All right. It is the number one leading risk factor for death. This is as far back as 20 year 2000. All right. As far back as year 2000, hypertension was the leading cause of death. All right. The leading, risk factor for death, followed by, tobacco. But the distance is very, very, significant. I mean, you can't compare. And then fast forward to 2010, hypertension still maintains, its lead. All right. It is still the highest, it's still the leading risk factor for death globally. And then 2019, hypertension still the highest risk factor, okay, for death is the number one risk factor for death globally. And I can tell you authoritatively that even in 2023, 2024, it is still maintaining the lead. Now, an entity, all right, that is the highest risk factor for death for over 24 years. And I can tell you that it's even, it dates back before that time. All right. This was just when, some of these things were being captured. But even before then, hypertension, has been, a very, very significant risk factor for death in so many climes and in the world globally. All right, it is recognized as a chronic, public health challenge, and we need to deal with it. And of course, I mean, because it's something that can be highly managed, it is something that we should talk about. It is something that we should, inform ourselves about, so that, complications and things like that, we can avoid it. All right. Like I said the last time, you know, um, managing hypertension is very, very easy if we will follow the process. If we will follow, the things that needs to be followed, and we key in into, you know, preventive stuff that we're going to talk about later anyway. But today we're looking at the impact of hypertension, and we're looking at the, clinical features of hypertension. With each 20 millimeter mercury increase in systolic blood pressure and 10 millimeter mercury increase in diastolic blood pressure, cardiovascular mortality risk doubles. I'm sure you saw this as well in the last edition. All right. And that is very, very important. All right. Blood pressure of 115 over 75. By the time the blood pressure is sustained at 135 over 85, the risk of death is already doubled. All right. And I guess that is why the US decided that, you know what, we're pegging our own definition of hypertension as a blood pressure of 130 over 80 and above. And I tell you that a number of other places are keying into that particular one. Hypertension journey has been very, very long, and it's been evolving. Maybe the next edition, we're going to look at the evolving nature of hypertension, and we'll go back to history and look at a few things. Okay, I didn't want to bore us with that the last time, but maybe we're going to look at that, just to put more light, into hypertension history for us. And by the time the blood pressure is 155 over 95 sustained, the person is already 4 times at risk of mortality. All right. By the time it's 175 over 105, is 8 times at risk. That tells us something, that it is not something that should be joked with. All right. And it's not something that, if you see your blood pressure, or someone sees his blood pressure, not being well controlled, and the person just says, oh, well, it doesn't really matter. I'm going to take Valium, I'm going to do this, I'm going to do that. It's much more than that. And we need to be very, very aware of this, and be able to, to do what is needful to make sure that blood pressure is well controlled. Now, let's go to clinical features. All right. Now, hypertension is tagged as one of the silent killers, and is the number one silent killer globally. Why? It's largely asymptomatic. Its asymptomatic nature may be for as long as 15 to 20 years. And while that is happening, the cardiovascular system may be getting progressively damaged. All right. And that is what makes it dangerous. Sometimes people actually present for the first time with very, very disturbing complications. All right. So hypertension, largely, asymptomatic. All right. Nothing, you're not experiencing anything big, anything major. Somebody can be walking with a blood pressure of 170 over 110 and is still going to work. Whereas if that person were to have malaria and is shivering and having, very high fever and vomiting, the person will call in and say, I'm not feeling fine, I can't come to work. But hypertension may not take that, that route. It may just be very, very quiet. And while it's there, it's damaging the cardiovascular system. It's damaging very vital organs. More than 50% of newly diagnosed patients, okay, that are, elderly patients, okay, that are newly diagnosed of hypertension already have complications. More than 40% of, the younger ones, 30 to 40% of the younger ones have complications, one complication or the other, by the time they are presenting. So the complication can be maybe cardiomegaly, that's an enlargement of the heart. You may do the chest X-ray and you find out that the heart is enlarged, or you do an ECG for the person and you find out that the person already has left ventricular hypertrophy and a few other things like that. Okay, so its asymptomatic nature makes it very, very dangerous. And that is why we've got to, catch it early, nip it at the bud to make sure that things don't go, sour for the person. As be that as it may, hypertension is a very, very well, is a very, very, well managed, is a potentially well managed illness or ailment. Okay, it's very, very easy to manage, so to speak, if the person will do the right things. And then maybe in the next session or two sessions from now we will talk about the management, and then you will see that really it is easy to manage. Number one. Two, hypertension, one can live well with it and still be very, very healthy. All right. And it's two different stories for two different people. So what do I mean? I mean, you can see a patient that is 40 years old coming in with heart failure, coming in with maybe stroke. And on the other hand, you can see a 90-year-old. I have 90-year-old, 87, 85-year-old patients who, if they don't tell you that they are hypertensive, you will never know, because they've been able to, to manage it properly with their physicians. And that is what we want to achieve, that people will be able to manage it well. It's my heart bleeds when I see young people, productive people, I mean, people in their productive age group, coming down with stroke, with kidney disease, 35, 45, coming down with such things. I mean, that shouldn't be. We can do better, and we can approach this thing in a much more, decent manner, that, people won't really come down with, with complications as much as possible. So number one, it can be very, very asymptomatic. And that is why we need to check our blood pressures regularly. Two, patients may have non-specific symptoms. Symptoms like headache, all right? I mean, just headache, lightheadedness, malaise. The person is not, the way I describe malaise, you are not sick, you are not well, all right? The person is not sick. At the same time, the person is not optimally up to it, optimally well. He just knows that there's something wrong somewhere. This is not my best, all right? He may, lie down in this place and then get up, and is very slow, and just feels a bit giddy, just feels unwell and things like that. It can be hypertension. And in this climate where we are, where everything is ascribed to malaria and typhoid, please beware. I mean, I've had patients who've told me that their only problem is malaria, typhoid, malaria. And I'm like, what did you do to typhoid and malaria? Because I mean, even typhoid and malaria, they are ailments, of substandard hygiene. So I tell my patients, I say that if doctors tell you that you have typhoid, they've only, as far as I'm concerned, they've insulted you, that you have not been too prudent in the things you eat, that you have taken in something that is not supposed to be taken in. And if they diagnose typhoid and malaria for you every day, you need to check your standard of living. You need to check your health, health seeking behavior. Number one, you need to check your standard of hygiene. All right, that means that there's a breach in your hygiene. Okay, because I mean, you shouldn't really be having typhoid and malaria. So lightheadedness, malaria, typhoid and malaria are not the only causes. Hypertension can cause it, and we need to be aware of that. Palpitation, when you feel your heart beat, when the heart is beating without any cause for it. All right, hypertension can cause that. The person should go see the doctor. I mean, tinnitus just means ringing in the ears. When there's, wow, 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 just, a continuous ring like um, sound in the ears, it can be as a result of hypertension. There are other causes, yes, but it can be as a result of hypertension. Okay, epistaxis, that's bleeding from the nose. Of course, if somebody is bleeding from the nose, nobody will tell that person before he quickly goes to, the hospital. That is an explosive thing. That is a very, very strange manifestation. So I'm sure that the person will go to the hospital. Blurring of vision. All right. If your vision is blurred and it's getting blurry by the day, please go, apart from going to the ophthalmologist, please check your blood pressure. And, if your blood pressure is controlled, it may just be, the beginning of you getting back your sight, because hypertension can also affect your vision. Insomnia means sleeplessness. And some people have very poor sleep. And this is what I want to say here. All right. A lot of people, when they don't sleep well, when they wake up the next day and the blood pressure is high, many people will ascribe the, elevated blood pressure to the fact that they were not able to sleep well. And so you hear people saying that, they couldn't, the blood pressure was high because they didn't sleep well. Yes, that may be part of the truth. But the other side of the coin is also even very, very true, that if your blood pressure is elevated, you may not be able to sleep well. Okay, if your blood pressure is elevated, it may not allow you to sleep. I mean, you can imagine somebody with a blood pressure of 200 over 110. There's not no the chances of the person sleeping will be very, very slim. All right. So insomnia, poor sleep can be a presentation, a subtle presentation of hypertension. I tell people, if you're having headache very regularly, or you're not able to sleep well, please check your blood pressure. If you have, you feel unwell, you just feel cloudy and all of that, please check your blood pressure. These are some of the things that hypertension can cause. And because they are non-specific, one may not look out for it. However, if one checks and is able to diagnose it early and management starts early, the chances of deteriorating will be very, very minimized, cut short, and as much as possible prevented. All right. So it's important that these things are known, and then we can act, in a very, very informed manner. All right, this is a little bit sketchy diagram. So headaches, very, very there. Dizziness, we talked about it. Confusion. I mean, by the time one is getting confused as a result of hypertension, the person has moved very far, because it has a term that we call it hypertensive encephalopathy. The person has moved very far. The brain is already being affected. Blurring of vision, difficulty in breathing. All right, the person moves a little bit, and then gets uncomfortable in breathing, okay, difficulty in breathing on exertion, that person needs to see the doctor. Or the person lies down and is not able to breathe well, orthopnea, all right, the person needs to see the doctor, okay. Chest pain, all right, sometimes exertional chest pain, the person walks, or takes, moves briskly, to the first floor, and then he has this left-sided chest pain, or retrosternal chest pain, that central chest pain. He has to hold on, and by the time he rests a little bit, the chest pain, eases off. That person needs to see the doctor. All right, something is going on there, and it may just be one of the presentation of hypertension. Vomiting, nausea, and vomiting, are also non-specific symptoms of hypertension. All right, reduced urination is a symptom of hypertension, or frequent urination at night. All right, we call it nocturia. That may also be one of the features of hypertension, especially when the kidneys are involved. So, these are things that we need to know about, so that we can, nip it at the bud, and I'm sure that it will help us. Let's look at, a bit of hypertension journey here, the normal history. All right. progress journey of hypertension from risk factors. We looked at all these risk factors last week. I mean, 2 weeks ago when we had let's talk about hypertension part one, obesity, inadequate physical activity, stress, tobacco use, unhealthy diet, type A personality, and things like that. We looked at all of them the last time. By the time these risk factors are there, the person may move to, pre-hypertension. All right. The person is not yet hypertensive, but the blood pressure is higher than the optimal blood pressure. The optimal blood pressure, according to WHO and the JNC, all right, is 120 over 80. Now, once it's above 120 over 80, something like 125 to 39, if you're going by WHO, that is already, pre-hypertension for that person. All right. 121 to 129, if you're using the American classification, that is already pre-hypertension. The issue with pre-hypertension is that if care is not taken, they can move forward, they can move on and become established, people living with hypertension. The blood pressure may just move over the fence, and by the time they check it, is chronically, or many a times, more often than not, 140 over 90 or 130 over 80 and above if you're in the US. All right. So very, very important. Now, at this point, pre-hypertension, things can still be done to move the person backwards, all right, to halt the progression as much as possible. What do you do? Lifestyle. We're going to talk about that later on. Now, in our second one, where we talked about prevention of cardiovascular disease, I'm sure that those who are there, you remember that I mentioned something about primordial prevention, all right, but we're not talking about prevention today, so we will leave this. We will leave this side of this history and journey for the time when we'll be talking about prevention and treatment of hypertension. Okay, fine. So hypertension, by the time the person is hypertensive, things can still be done. Now, somebody can be hypertensive without having complications. It is very, very possible. And there are few people that are living with hypertension and have without any complications. All right. But these people are, very, very determined to make sure that their blood pressure is well controlled. They take their drugs regularly. They keep their clinic, appointments. They raise their game as far as lifestyle modification is concerned. You can see here, lifestyle modification. So they raise the bar as much as possible. They don't just indulge. They don't just take things anyhow. They exercise. They cut down salt intake. They take more fruits and vegetables. All right. For those who are obese, they cut down on their weights deliberately. All right. They stop smoking. They stop alcohol intake and things like that, just to make sure that they do not move over. All right. And it is possible to live with hypertension and not have, complications. Very, very possible. But if the person is slack in, maintaining all of the things I've said, not taking drugs regularly, now there are people that say, oh, when their blood pressure is well controlled, the next time they will not take it because they feel that if they take it, it will go down and it will become low. The fact is that if your blood pressure is well controlled, it's the drugs that are doing their work. You need to keep taking the drugs to make sure that the blood pressure is kept at that point and it's not more than what it ought to be. Okay, so hypertension is something that somebody can live with and not develop complications. But if the person is not able to do all the things that have been said, then that person can move on to early complications. All right. What are the early complications of hypertension, cardiomegaly? That's enlargement of the heart. The person will do chest X-ray. They will say, your heart is just a little bit enlarged. The person that is just a little bit enlarged. The person does ECG, okay, and then they find out that the left ventricle is a bit hypertrophied. All right. Or even during examination, the heart is a bit enlarged from the examination. Early complications, all right, or the kidneys are not doing their work the way they ought to. The person is waking up 4 or 5 times in the night, and by the time you check it, no other reason for that particular thing. It may just be that the person have started having early complications of hypertension, and by the time you check kidney functions, you may just find out that some things are just a little bit elevated here, a little bit elevated there. And if care is not taken, the person can move to the full-blown end-stage complications of hypertension, may develop stroke, heart failure, and all of the rest. And these are the things we don't want people to develop. So in this particular journey, if you look at it very well, what this is telling us is this, that the hypertensive of today, if not well controlled, is the stroke patient of tomorrow, or the heart failure patient of tomorrow, or the kidney disease patient of tomorrow. So please, we need to make sure that hypertension is well controlled. The blood pressure is well controlled. And if we have people who are hypertensive, parents, uncles, aunties, we need to help them to give them the knowledge so that they can be able to manage it well. This is the natural history. It's just about the same thing that I've talked about over the pre-hypertension. So I'm not going to waste time on this. Pre-hypertension and then early hypertension. You can move the person back to normotension with very, very aggressive management and very disciplined management plan for that person. And then the person gets to establish hypertension. Now the age range changes. It doesn't need to follow this pattern. We've had people who are 35 years old who already have complications. Established complications. So established hypertension, you can see uncomplicated. People can live with hypertension without having complication, and then people can live with it, trying to grapple with complications. All right. Cardiac failure, aneurysms, renal failure, stroke, and the rest. Okay. Hypertension is just a tip of the iceberg if not controlled. The numbers is not really what worries us. It is what is going on underneath that is worrisome. Numbers don't kill anybody. It is the impact of the numbers that kills. So if somebody is going around with a blood pressure of 150 over 100, it is the impact of that 150 over 100 on the organs beneath, the things we cannot see. Those are the things we are worried about, because the person is at risk of having stroke, ischemic, transient ischemic attack, of having peripheral vascular disease, of having renal failure, heart failure, heart attack, and the rest. These are the things we are worried about, and that's why hypertension has to be well managed. All right, so let's quickly look at the complications. I'll be rounding up now. Complications of hypertension. Let's look at the 5 C's. All right, the 5 C's of complications of hypertension, and this can help us to remember well. Number 1, coronary artery disease. These are those who have ischemic heart disease. This is a step to heart attack. All right, somebody who has coronary artery disease, is not well managed, can have full-blown heart attack, and heart attack kills. All right, chronic renal failure. I've mentioned it in passing while talking. Chronic renal failure, and then the person, if not well managed, can get into end-stage renal disease. All right, where he will need dialysis and all of that, and renal replacement therapy and the rest. Congestive heart failure. All right, the person can have heart failure, may not be able to walk from here to there, will be breathing as if he's just finished the 100-meter dash. okay, when he has not even moved up to 10 meters. Can you hear me? Please write yes. All right, fine. Thank you very much. Okay, fine. So, cardiac arrest and then cerebrovascular. Thank you very much, sir. And thank you very much, sir. Coronary artery disease, chronic renal failure, congestive heart failure, cardiac arrest, cerebrovascular accidents. All right. But then there are other complications, and these are subtle complications. Okay, arrhythmia, and this is I arrange it as A, B, C, D, E. All right, just to make us to understand a bit better. At least we may be able to recall and have this at the back of our mind. So arrhythmia or aneurysm. Arrhythmia is abnormal heartbeats. The person will usually complain of palpitation. Sometimes the heartbeat can be irregular. Person will just say the heart wants to jump out. It's just running as if something wants to jump out. It's like as if what's going on? What's going on? That's arrhythmia. Okay, aneurysm is abnormal dilatation of the great vessels, sometimes dilatation of the aorta, and sometimes if an aneurysm gets dissected and erupts or bursts, or it can be very, 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 very devastating. It causes death very, very easily. All right. And for some people, the aneurysm can be in the brain. And if it's, ruptures, the stroke that such patients have can be very, very, life consuming. Okay. B, blindness. So hypertension can cause blindness. It can cause progressive blindness. It can cause sudden blindness, irrespective of whether the person has glaucoma or not. All right. Hypertension can on its own cause blindness. Another B, hypertension can cause progressive bone loss, such that the person, from just very, very insignificant activities, the person can have, fracture and few other things. The bone is so fragile, anything can happen. So bone loss. C, cognitive impairment. So hypertensive patient can have cognitive impairment. Sometimes they can be very, very slow, in initiating movements, initiating actions. Sometimes they can be completely off course. You see somebody who has lost, all the inhibitory mechanism. The person just, the person can wee wee over here, poo poo over here, do this and that. The cognitive balance and wellness is no more there. Dementia. I'm sure that a lot of us must have heard about, what dementia is. Okay, chronic, progressive loss of, activities, fine detailed activities, of the brain. The person is unaware of what is going on. He can do things anyhow. It's just a problem. All right, because of the vascular impact of hypertension in the brain, and also there can be chronic systemic impairments. Okay, chronic systemic impairments. A lot of things can just begin to go haywire. The person is not completely in these frank stuffs, but at the same time, the systems are not just working well. Hypertension can cause that. All right, disabilities. Hypertension can cause disabilities. Okay, peripheral arterial disease. Patients can lose their limbs. There are people who have lost their limbs because of hypertension. All right, when blood supply to the legs are just cut off because of combination of hypertension and atherosclerosis, and if you don't cut off the leg will cut off that life. And we've had people that we have had to struggle with. Let this limb be removed so that your life can be spared. They said, no, I don't want it. Do drugs, do this. Before you know it, that limb claims their lives. All right. So disabilities are there. Again, somebody who suffers stroke may be wheelchair bound for life. That's a disability. The stroke is currently not there. Maybe he has escaped the stroke. The stroke did not kill the person, but the person lives with one mark, major mark forever. The person may be wheelchair bound. The person may need to use walking stick or frames and things like that. That's a disability. All right, and of course, hypertension can cause death. It can cause sudden death. The first presentation of hypertension can be death. All right. Hearing dysfunction and hearing loss. Hypertension can cause vestibular dysfunction. All right. There can be bleeding into chronic loss, chronic progressive loss of hearing functions. All right. And dysfunction and loss. And for men, erectile dysfunction, hypertension can contribute to it. So you can see that hypertension can affect almost every part of our body. All right. And that's why we've got to take care of it. We've got to really, really be intentional about making sure that if one is hypertensive, please don't joke with your management. All right. If you know somebody who is hypertensive, maybe a friend, a colleague, an uncle, an aunt who is not taking his or drugs regularly, just feel that, okay, we've said that this is a silent killer. It may not show face. All right. Because of that, the person is not taking it seriously. Please tell that person, please don't joke. Don't joke with this. It's not the best to joke with it. All right. So elevated blood pressure is the leading risk factor for global burden of disease. We've talked about that. So hypertension is associated with 69% of first myocardial infarction, 74% of cases of coronary artery disease, 77% of first stroke, 91% of heart failure. It's extremely important that we deal with this thing so that it doesn't cut short, our people, and then so that we don't have lots of disabilities all around us. I think we should stop here for today so that we can give room for questions and for us to interact. We have about 15 more minutes. I think we can stop here for today. I hope that this has been beneficial to us. We will continue in 2 weeks' time, but in that 2 weeks' time is going to be a Sunday. We will let us know. We'll bring out the flyer on time so that everybody can get ready for it. Thank you very much. God bless you. So the floor is open for questions, for reaction. You can ask your questions in the chat box if you wish, and you can raise up your electronic hand, so that you can be allowed to ask your questions. Yes. Please, host, can you help us unmute Mr. Akin Adamolekun? He's raising his hand so that he can ask his question.
Thank you so much,
You have the floor, sir. You have been on. Thank you, sir.
Okay, sir. Thank you so much, sir. Yes, sir. This is my first time joining this program. I really appreciate your time and your presentation. I was invited by a friend. I said, let me give it a try, and it's very impactful. So I want to ask this question, sir. Is it true that overthinking can cause hypertension? That's just my question. Maybe when you bother your mind too much on something.
Okay, thank you very much, sir. If you are around for the last one, no problem. If you were around for the last one, you dealt with that. But Dr. Doye, can you help us with that? Overthinking. What say you? Dr. Obieli. Oh, please help me to unmute Dr. Doye, Dr. Obieli. I think I can see some other colleagues in the building. Please feel free if you want to contribute. You can raise your electronic hand so that you can be allowed to the floor. I'm not sure we can hear you.
Good evening, sir. Good evening,
Good
sir.
evening, sir.
Hi. Okay, this is Dr. Daniel speaking, sir.
Yeah, good evening. You can go ahead.
Okay, good evening to the
Yes, please.
house.
Go ahead, please.
Okay, sir. So with respect to the question, overthinking, let me start by saying that I'm sure everyone in this economy and in Lagos as it were now would definitely think, okay? But a form of emotional instability that may actually deny you of your sleep, that makes you feel like withdrawing to yourself, that makes you lose interest in life as it were. When it keeps getting to that point, then it might actually impact on your health. But everyone would normally think about one thing or the other. So basically, thinking generally, baseline speaking, shouldn't be an issue. But when you're so worried, you're so anxious about everything, you are losing your sleep. I think at that point, then you may need to see your doctor, and it may not just be seeing a cardiologist. You may even need to see a mental health person to also help see what the problems are basically going forward. However, so a number of people are predisposed to having hypertension. Okay, if your parents are hypertensive, your siblings are hypertensive, there's a likelihood that you might have hypertension, whether you think or you don't think. Okay, sometimes those stressors may just actually allow such presentation to come up earlier. Okay, when you are stressed up, apart from even overthinking, whatever any form of stress as it were that denies you of your sleep, you don't sleep well, you don't rest well, those things could actually help to open you up as it were if you are already predisposed to having hypertension. But generally speaking, thinking as it were wouldn't be an issue, okay? But when it actually moves beyond the boundary of what I call normal, when you are possibly losing your sleep because you're worried about a particular matter, you're losing interest in wanting to eat, or you're overeating as the case may be, at that point, then you might need to see a mental health physician, and then there might be also be need to see a cardiologist. I wouldn't know if that explanation will suffice for the question, sir. Thank you.
Okay, thank you very much. I think it's been well put. Yeah, I mean, everybody, we have we are rational beings, we are emotional beings, and we are intelligent beings. I mean, you've got to think. Sometimes, and I guess this person is coming from the angle of sometimes you present in the hospital and a very junior. Well, I want to believe that doctors shouldn't be asking that question. Um, maybe a chemist or somebody who is not really have not gone through the real training of medical stuffs will be asking patient, what are you thinking? Stop thinking. What are you thinking? I'm like, come, if you want to exist in this world, this is a world of thinkers. All right. But of course, if it gets overboard, like Dr. Don you have said, then it can actually predispose one to, to hypertension and some other chronic illnesses, and you need to see the doctor for that. Thank you very much, Dr. Donny. Yeah, I think I saw one another, and Chinyere, Madam
Okay.
Chinyere, I think.
Yeah. Good evening, doctor.
Yeah,
Good
please
evening,
go ahead.
everyone. Good evening, everyone.
Good
Thanks for
evening,
this
ma'am.
session. Very, very insightful. Thank you so much. I just wanted to know, please, is there a difference between heart attack and cardiac arrest? Are they used interchangeably, or is one just for maybe, or we say the colloquial, somebody had a heart attack, I don't know. So I just wanted to know if there is actually a difference or whether they're one and the same thing. Thank you.
All right, thank you very much. I think we dealt with this last time. Sure, actually, this question I've been a recurrent question in the last two sessions we've had. Dr. Donny, do you want to give it a shout for us? And then maybe I'll take the others. And there are other doctors in the house. I can see Dr. Ali. Thank you very much, Dr. Ayotunde Ali, wonderful colleague and endocrinologist par excellence. And a few other colleagues that are around that I can see. I'm sure that they will also want to join this. But Dr. Donny, yes, please, you can help us.
Okay, sir. Okay, sir. So to answer your question, ma'am, you said heart attack and then cardiac arrest. Okay, so maybe I should just take it from this approach from the presentation we had earlier today. There were points where they were talking about sorry about using medical terms, acute coronary syndrome. Okay, whereby you have sudden cessation of blood supply to the heart. Okay, and when that happens, it's said to be like a form of an attack to the heart, an attack to the heart, basically. So the English word, so to speak, would be has an heart attack. He has an heart attack. Okay, and maybe for the medical point of view, but by the time you begin to use the word cardiac, it's still another way of saying heart, as it were, like that, to have an heart attack, basically. So from what we've learned today, hypertension could also predispose people to having a heart attack. Okay, when you have elevated cholesterol levels, we can clog vessels that supply the heart, basically can cause a form of a heart attack, basically. So so when blood supply to the heart is compromised, okay, and then is blocked, if I could using English words as it were, then you could actually have that. And a number of times we also tend to mistake it with heart failure. Some people will say heart failure or heart attack. So for heart failure, a number of times it's just when the heart cannot pump blood adequately to meet your need. Okay, you need to move around, you need to walk up and down, get things done. So when the heart can actually pump enough blood to meet your basic needs is when we say there is heart failure. Okay, but for when we say there's heart attack, okay, you could actually have obstruction to blood supply. Okay, and for cardiac arrest, okay, let me just explain this. A number of things can also cause the cardiac arrest. Okay, there are what we refer to as electrical activity of the heart. Okay, whereby you could have a sudden cessation of cardiac function. A number of things can cause that. I don't know, it might be difficult to start explaining to details, basically. But for each one of them, heart failure, the heart can't pump well. Okay, heart attack, the heart is not getting, there's a blockage. Then for cardiac arrest, basically, like sudden cessation of the heart, which might be due to a lot of issues, basically. Thank you.
Okay, thank you very much, Dr. Donny. So heart attack can lead to cardiac arrest, and there are so many other things that can cause cardiac arrest. I mean, just like Dr. Donny has said, sudden cessation of blood flow through the heart will cause heart attack, and it can kill. All right, it can kill. I mean, the first presentation may just be sudden death. All right, thank you very much. I hope that answers your question. Any other question, comments? I don't know whether there are questions in the chat box. Any other questions, comments, and things like that? Does BP lead to swelling of the legs? Okay, somebody is asking, does BP lead to swelling of the legs? Yes, it can. All right, so I mean, there are so many things that can cause leg swelling. All right, and just like the symptoms and signs that we looked at, uncontrolled hypertension can cause, leg swelling indirectly if the kidneys are involved. All right, if the person, begins to have chronic kidney disease, all right, as a result of the uncontrolled hypertension, the legs can get swollen. That's one. Two, if the person goes into heart failure, all right, both the left and the right, heart failure, the person can have, what do you call it? Leg swelling as part of the symptoms. Okay, so congestive heart disease, and we mentioned the congestive heart failure. All right, is one of the causes of of leg swelling. in people. So yes, somebody, hypertension can, lead to leg swelling in people. Yeah. Any other questions, comments? You can raise your electronic hand so that we can. Yes, please, Miss Chinyere Honor. Please go ahead. We can't hear you. Please, can you unmute Miss Chinyere?
Okay, are you hearing me now? Hello?
Yes, please.
Yes.
Yes, please.
I made this observation, and I don't know whether this is the appropriate time to ask, but I've made the observation that over time, there's a tendency to move from one BP drug to a higher one, and then to a higher one, and another to a higher one. So sometimes for BP patients, it gets quite scary because you get the fact that maybe when you get to, there'll be a time when the drugs you will take will no longer be effective. You understand? Because I knew when I started my BP journey, then it was Brenadine. Then I think they said Brenadine wasn't that good for the heart, that it wasn't for the heart anymore, something that it wasn't the right drug. Then we have Aldomet, then we had a Moderatic, then I moved that. I've been moving on, and suddenly I'm in Xforge. Do you understand? So I want to know why the move from one drug to the other, and the scare that maybe one day I might actually have to take a drug. I might actually have I might be prescribed a drug, or I might come to the end of my theta. There'll be no drug to control my hypertension. So that's basically where I am. I don't know. Okay.
All right. Thank you very much. No, you won't get to that point. The world is evolving. Thank you very much. Thank you very much. Yeah, the world is evolving. Medicine is evolving. All right. Everything is changing. Now, I am very sure that you've changed phone. Even this phone we're talking about that we're using now, I'm sure that you have changed phone several times. So Bernardine's era is gone forever. Okay, it's done its own bits. Bernardine cannot compare with the drugs we have now in terms of efficiency, in terms of potency, in terms of, cardioprotective benefits that it brings to the table. Same thing with Aldomet. All right. So when the drug started, we're going to get to that. I think that should be the very last of the attention series, maybe attention 4 or 5. All right, but since you have asked that, let me just answer this now. So when the whole journey started, all that was being looked at is let's control the blood pressure. But now we've gone past that. We're not just looking at let's control the blood pressure. We're saying let's control the blood pressure and let us protect the organs. Okay, if you look at what the slide I put there, hypertension is just a tip in the iceberg, of the iceberg. The numbers, yes, the numbers are only significant when it comes to the complications that they cause. So if you have a drug or if you have drugs that can not only control blood pressure, but also give your system some form of protection, I'm sure that you will want to go for those ones. Just like, when GSM came into Nigeria, all we're doing is just send message and call. But now you can do video calls, you can do this, you can do that. You've moved on, you've dropped all those other ones. That's the same way that there's a evolution in the management of hypertension, and it's not only in medicine. It cuts across almost every discipline in life. All right. So don't be tired. We're just, the pharmaceutical world and the medical world are just trying to give you the best, so that everything can go well. All right. And that's the beauty of going for your clinic visit. Because if a drug comes and And studies have shown that, oh, this drug is very, very beneficial, does this, reduces. There are drugs that reduces mortality, all right, among our antihypertensives. Now, if I don't give it to you and I know that this drug can dramatically pull you away from the red line, that would be very wicked of me, it can be termed as negligence of duty. If I know that a drug can protect your organs as well as control your blood pressure, and I deny you those drugs, I don't think I would have done you much service. I mean, acceptable service. So, you don't need to be afraid. Things are just evolving, and I can tell you. Then the other thing is this: the safety profile of the drugs we have now are quite better, far better than the Brinadines and the other ones that you have mentioned of this world. All right. I hope that answers your question.
Yeah. Thank you very much.
Thank you very much.
Thank you.
I think I saw phonics. You're welcome. I saw somebody phonics, the hand was raised or something. I don't know whether there's any question in the chat box. I'm taking amlodipine and also taking nifedipine. No, you cannot take the two together, please. They are in the same family. Amlodipine and nifedipine are both calcium channel blockers. Your doctor, I'm sure it's not a doctor that gave you this. I am very, very sure that maybe you are on amlodipine and maybe your friend says, oh, this one is working for me. And then, I don't know, maybe you now decided, please, you have to drop one. You need to go see your doctor, or you need to contact us so that we can give you, appropriate combination, that will help you, please. How can one lower the cholesterol level? You're dragging us out of our focus for today. There are so many things to do to lower cholesterol level, where we still get to that. All right. But first of all, your diet. So you have to cut down on the intake of saturated fats, fatty meals and things like that. I think we discussed that in our second session when we looked at prevention of cardiovascular diseases. We will send that recording to you. You can go through it. I'm sure that will will really help you. If there's a link over there, if you can click the link, we will send all the recordings. This is our fourth session. We will send everyone first, second, third to that platform. Everybody can get it, and I'm sure that it will benefit us. I'm currently taking amlodipine, losartan, and vasopressin. Yeah, that's good. That's a good one, and I think that it should be able to control your blood pressure. But if it doesn't, you may want to reach out onto us. We may maybe need to increase the dosage or juggle one thing or the other for you, so that you can have good blood pressure control. All right. Okay, we're winding down now. I would like to. Any other question, comments? I want to give room for some of our other specialists in the house to talk. Dr. Ayotunde Host, can you help us unmute Dr. Ale Ayotunde, a very good friend and a colleague. She's an endocrinologist. And then I think I saw Kenneth. Yeah, help me unmute Onyocha Kenneth, a colleague of mine as well. I think I saw Taiwo, Dr. Taiwo. Dr. Taiwo, if you're around, you can raise your electronic hand so that they can unmute you. Doctors in the house, no prejudice. I know that we all have a busy schedule, but we want to say thank you to you as well in this. So, Dr. Ali, you can talk, or Dr. Kenneth. Yeah.
Yeah, thank you very much, Dr. Sonia. It's good hearing from you once again. I got this link to our group now, the YBC 97, yeah. So I said, let me join. Today, my first experience of this lecture. I'm joining for the first time. I think I must say that it's a place to be, even for doctors do for our patients too. I must have benefited so much. Even being a physician too, that's something I have taken away. So my patient can also benefit last time. Father Gabriel Orishagu, I think he's here. And a lot of them, I had to send this to a lot of my patients to benefit from this lecture. Thank you.
Oh, wow.
It's a great
Thank you.
opportunity to be here. Thank you very much. I hope I will have time to join the other session that will yet to come.
Wow. Thank you, Kenneth. Yeah,
Thank you very much. Keep it up. Sorry.
All right. Thank you, Kenneth.
Thank you very
Kenneth,
much.
on your chat, thank you very much. All the way from the US. Thank you very much for joining us. Dr. Ale, we want to hear your voice, please. Can you help me unmute Dr. Ale Ayotunde? Host Ayotunde Ale, please. While we round up.
Good evening, everyone. Good evening.
Good
Hello.
evening, Doc. How are you? Yeah, we can hear you. We can hear you.
Sorry, I wasn't really. I was doing something. I also listened to the program. So it
All
has
right.
been a
Okay.
nice.
Thank you.
Yes, thank you very much for the nice presentation. Yes, thank you.
All right. Thank you very much. Thank you very much. And we want to thank all the doctors in the house. We want to thank everybody who have made out time to attend this one, especially the very short notice. I was just wondering how I hope people will be able to attend this one. The last one that we had, I could recall, were 115. That was the last I counted, 115. Today we're 61. That's quite impressive, knowing fully well that it was only yesterday that we had to come up with this and say, you know what, instead of missing the whole day, instead of missing this week out completely, let us do something. And 60, I think the highest number I saw was 65, 66. I must thank everybody. Thank you for your patience. Thank you for your swift response. Sorry for disrupting your program. And some of our other doctors also sent in the apologies. Dr. Billy came in along the line, but she's on the road. Lagos, hold up, and maybe she's in a place where there's no network now and things like that. But we want to say thank you to everybody for making out time to join us for this particular one. In 2 weeks' time, by God's grace, is going to be on a Sunday, our traditional day, 7 p.m. We will get the flyers out on time to prepare everybody. We will be meeting again for an hour with a cardiologist, and we're going to look at hypertension. Let's talk about hypertension part 3. Oh, wow. Dr. Tokwe Adediran. Wow, thanks a lot. Host, can you help me unmute Dr. Tokwe Adediran? A colleague of mine is in mental health, is in Canada. And thank you for joining us. Please unmute him. Let him say hello to the house. Tokwe. Dr. Adediran. Toluwa Tokwe Adediran. Please help me unmute him, please. Host. Kindly help me unmute Dr. Toluwa Tokwe Adediran. Kindly help me unmute Toluwa Tokwe Adediran. Tokwe, please unmute yourself. You'll be unmuted. Dr. Toluwa Tokwe Adediran, click the unmute button and you'll be able to speak. Okay, maybe he's having a network problem. He just chatted us up and said, well done or something like that. Thank you very much. So we will meet in 2 weeks' time. Thank you, everybody. We appreciate you. If you got value for this time, can you just write that? I mean, you got value, or just write something to help us know. Okay, Toko, yeah, you have the floor.
Okay. Thank you very much for the wonderful lecture, Sonia. Sorry, I didn't catch it from the beginning because I just got home now. And but I will definitely look forward to joining you for the next one. So thank you very much for doing this. It's been very educative.
Thank you.
Okay.
Thank you very much. All right. Thank you, everyone. I think cheers. Well done. All right. Bye. So we will do this again in 2 weeks' time. We'll be looking at hypertension part 3. And for that one, we will start going into, some investigations. I mean, the level of patient's understanding. We can't do investigation to the point where, we can't do it up to, medical practitioners level, but we'll explain few things to us. All right. Some questions that people ask about investigation. What does this mean? What does that mean? We'll try to explain, and then we'll talk about management, and why some drugs are used, preferred over another, and all of those things, But I promised us we're going to look at hypertension history. So we'll do all of that after hypertension history if we still have time. Thank you very much. Enjoy the rest of your day. We're very grateful for this. Thanks for joining us. Thank you, everyone. Have a nice day.